Welcome all of you. We are going to see the topic malaria. So the word malaria, it came from the two terms bad air. Mal meaning bad and area meaning air. That is because it was thought that this disease is spread by air pollution. And the causative agent is Plasmodium, and this was discovered by Alphonse Laveran. And Plasmodium has got two cycles, sexual as well as asexual cycle. Sexual cycle take place in the female Anopheles mosquito. This was described by Sir Ronald Roos. So the agent is Plasmodium. It has got 5 species: Plasmodium vivax, falciparum, malariae, ovale, and knowlesi. So the fever periodicity, it varies for the different species. Based on the fever periodicity, we can classify it into tertian malaria, quartan malaria, and quotidian malaria. Plasmodium malariae causes quartan malaria. Quartan malaria means the fever periodicity is once in 72 hours. And Plasmodium knowlesi causes quotidian malaria. That is, fever periodicity is once in 24 hours. The other species, Vivax, falciparum, and ovale, causes tertian malaria. And among the 5 species, only Plasmodium falciparum causes malignant malaria. The term malignant malaria is given because the symptoms are severe and it can lead on to complications also. All the others are benign malaria. Since knowlesi is a pathogen mainly affecting monkeys, it is also known as simian malaria. Coming to the life cycle. So this organism Plasmodium, it has got 2 hosts. The definitive host is female Anopheles mosquito, where the sexual cycle happens, and intermediate host is man, in which the asexual cycle happens. So the mode of transmission is the bite of female Anopheles mosquito, and these are the species of female Anopheles mosquito that acts as the definitive host: Anopheles stephensi, fluviatilis, and culicifacies. So in different geographical areas, different species are seen. Rarely it can be transmitted by blood transfusion or transplacental transmission. So when it is transmitted by female Anopheles mosquito, by the bite of female Anopheles mosquito, the infective form is sporozoites. And when it is transmitted by blood transfusion or transplacental transmission, the infective form is trophozoites or merozoites. Coming to the life cycle in humans. There are 3 stages. First one is the hepatic stage, also known as the pre-erythrocytic or exoerythrocytic stage. Second is the erythrocytic stage. Third one is the gametogeny. So the sporozoites are introduced into the human blood by the bite of the female Anopheles mosquito. It will reach the liver. Soon it will reach the liver. In the liver, the sporozoites are transformed into trophozoites. Trophozoites is the multiplying stage. And in the trophozoites, it undergo nuclear and cytoplasmic divisions to form pre-erythrocytic schizone. The pre-erythrocytic schizone will undergo maturation and develop the merozoites, which are released by the lysis of the cell. So at the end of the pre-erythrocytic schizogeny, or the exoerythrocytic stage, or the hepatic stage, the hepatic merozoites are released into the blood. In the hepatic cycle, few sporozoites, instead of getting transformed into trophozoites, they will be converted into hypnozoites. These hypnozoites are responsible for the relapse of malaria later on. These will not be converted into trophozoites immediately on infection. They will remain in the dormant stage, and later on they will get reactivated and cause relapse of the infection. Coming to the RBC cycle, or erythrocytic schizogeny. So these hepatic merozoites, they can infect the RBC. In the RBC, again, the hepatic merozoite will be converted into the trophozoite form. Here, the trophozoite form, even inside the liver, the hepatic cycle, also the trophozoite form has got early trophozoite and late trophozoite form. Early trophozoite is known as the ring form, and late trophozoite is known as the amoeboid form. In the RBC cycle also, The early trophozoite is known as the ring form, and the late trophozoite form is known as the amoeboid form. And this late trophozoite form, it will undergo nuclear and cytoplasmic division to form the immature schizon, which will undergo maturation to form the mature schizon, and this will release the erythrocytic merozoites. This is the erythrocytic schizogony. At the end of this erythrocytic schizogony, erythrocytic merozoite will be released that can infect the other RBCs. Like this, the cycle will continue. At one point of time, this erythrocytic merozoites, after multiple cycles, they will get converted into the gametes. That is the female and male gametes. And this is known as the gametogeny. So macrogamete and microgametes will be formed. That is the gametogeny. So these are the stages of life cycle happening in humans. Now the life cycle in mosquito. In mosquito, it is a sexual cycle that is happening. So mosquito, when it bites humans, it can take up the sexual forms as well as the asexual forms. Sexual forms is the gametes. They will take up the gametes as well as the asexual forms. But the asexual forms will get digested inside the mosquito, and only the sexual forms will develop. So that is the gametocytes. They undergo further development. So this is the sexual cycle happening inside the mosquito. The macrogamete and the microgamete undergo fertilization to develop the oocyst, then to develop the zygote, then the ookinete, then further it will develop into the oocyst. And this mature oocyst will contain the sporozoites, which are then carried to the salivary glands of the mosquito. When they bite the next human being, it will be introduced into the human being. This is the sexual cycle that is happening inside the mosquito. Now, what is relapse and recrudescence in malaria? Relapse, it happens in Plasmodium vivax and Plasmodium ovale infections. As I told, it is because of the hypnozoites. That is, few sporozoites, instead of getting converted into the trophozoites in liver, it is converting into the hypnozoites, which are the dormant forms. It can remain inside the liver for weeks to years, and later it get reactivated to cause relapse of malaria. But recrudescence, it is seen in two species, falciparum and Plasmodium malariae. In Plasmodium falciparum, it is due to the persistence of drug-resistant parasites. So recrudescence is basically due to the persistence of drug-resistant parasites in Falciparum malariae. In Falciparum malaria, in Plasmodium malariae, it is due to long-term survival of the erythrocytic stages at a low undetectable level in the blood. This is the reason for recrudescence in Plasmodium malariae. Now, the differences between various species of Plasmodium. First, about relapse. Relapse is seen in vivax and ovale. Recrudescence, it is seen in falciparum and malaria. And the erythrocytic cycle. Erythrocytic cycle means the duration it takes for one cycle to get completed and the release of merozoites, erythrocytic merozoites. It takes 48 hours for almost all species except for malaria, where it takes 72 hours. That is why malaria produces quartan malaria and other species produce tertian malaria. And in Nolacy, it is quotidian malaria, so it is only 24 hours erythrocytic cycle. Then the pre-patent period. Pre-patent period is the period between the entry of the parasite into our body and the period by which the detectable form of the parasite is seen in blood. That is the pre-patent period. This also varies for various species, the longest being for Plasmodium malariae. Then the incubation period, that is the period between the entry of the parasite into our body and the development of symptoms. That also is longest for Plasmodium malariae. About Plasmodium knowlesi, it is a parasite of monkeys and it can rarely affect the humans. First case was reported in 1965, and the vector in case of Plasmodium knowlesi is Anopheles leucospirus. Anopheles leucospirus is the vector, and the clinical features, it is quotidian malaria, that is 24-hour RBC cycle. Clinically, it resembles Plasmodium vivax. it has got more resemblance to Plasmodium vivax in the clinical symptoms. It causes acute illness with relatively high parasitemia and can infect all RBC stages. Now coming to the clinical features, pathogenesis and clinical features in benign malaria. So benign malaria means symptoms are milder. It is caused by all the 4 species and it is characterized by a triad of febrile paroxysm, anemia and splenomegaly. This is the triad, the 3 clinical manifestations. Febrile paroxysm, anemia and splenomegaly. This triad will be seen in case of benign malaria. So febrile paroxysm, it corresponds to the release of the successive broods of neurocytes into the bloodstream at the end of the RBC cycle, and it varies between species. So this fever paroxysm, it has got 3 stages. First stage is the cold stage, which lasts for 15 minutes to 1 hour, and then the hot stage and a sweating stage. So these are the 3 stages in the fever paroxysm. And after these 3 stages, the patient will get exhausted and tired and will go to sleep. So initial phase, the patient will get chills and all. Then flushing stage and finally the sweating stage. Then the other manifestation in the triad is anemia. That is normocytic normochromic anemia, which is due to lysis of RBC due to the release of neurocytes. When the neurocytes are coming out, it is by lysing the RBC. So that is the reason for this normocytic normochromic anemia. Another reason is the spleen. It is an area where the infected cells are removed. So the infected RBCs will get removed in the spleen. Along with the infected RBC, the uninfected RBCs that are coated with the immune complex can also get removed. That is also the reason for anemia. Third reason is bone marrow suppression, leading to decreased RBC production. These are the 3 reasons for normocytic normochromic anemia in malaria. Third one is splenomegaly. So the spleen, because it is removing the infected RBC, it will get enlarged due to the massive proliferation of macrophages that engulf the parasitized and non-parasitized coated RBC. The spleen become enlarged and palpable. Those are the 3 features of benign malaria. Now the features of malignant malaria. So malignant malaria, it is seen in Plasmodium falciparum. Plasmodium falciparum has got Plasmodium falciparum erythrocyte membrane protein, PFEMP, that is responsible for the clinical features and pathogenesis in Plasmodium falciparum. This PFEMP, it can cause these cytoadherence, rosetting, and it can help in escaping the splenic clearance. That is, because of the surface membrane protein, this RBCs which are infected with Plasmodium falciparum, it can adhere to the walls of the blood vessels. That too, the blood vessels in the deep organs. So it will adhere to the endothelium of the blood vessels in deep organs. That is known as cytoadherence. The next step is rosetting. That is, the infected RBC can form clumps with non-infected RBC. It can get sticky and it can attach to the non-infected RBC also. That is the rosetting. So cytoadherence and rosetting. As a result of these 2 process, what will happen is the RBCs, the parasites will get sequestered inside the deep blood vessels. Sequestration of the RBC will happen and this will escape the splenic clearance also. Because of these features, that is sequestration or holding back of the parasites in the blood vessels of deep visceral organs like brain and kidney. So the parasite is not coming to the spleen for the splenic clearance. So it is escaping the splenic clearance. This leads to blockage of vessels, congestion and hypoxia of internal organs. That is responsible for the manifestations of Plasmodium falciparum. So malignant tertian malaria. Now, the complications of falciparum malaria is because of this sequestration and all, it can cause cerebral malaria, infecting the deep vessels of the brain, causing CNS manifestations. Then pernicious malaria. Pernicious malaria is characterized by black water fever, algid malaria, and septicemic malaria. These 3 together is known as pernicious malaria. And black water fever is due to the involvement of the kidney. It results in the hemoglobinuria and darkening of the urine, that is black water fever. Then algid malaria means the patient will develop hypotension and cold clammy skin, that is algid malaria. Then septicemic malaria, these three together known as pernicious malaria. Other complications are pulmonary edema, adult respiratory distress syndrome, because it affects all the organs. Then hypoglycemia, renal failure, bleeding, disseminated intravascular coagulation, severe jaundice, all these are complications of falciparum malaria. And even the anemia will be very severe. Then acidosis. These are the complications seen in Plasmodium falciparum. And the chronic complications which are seen in all the types of malaria are tropical splenomegaly syndrome, quatern malarial nephropathy, and it can promote Burkitt's lymphoma. So tropical splenomegaly syndrome, it is because of the hyper IgM, that is immune complex mediated disease. And there will be hyper IgM and splenomegaly. Then quatern malarial nephropathy, that is the patient will develop nephropathy with the involvement of the liver. It can be seen in all the species of malaria, but it is most commonly seen in falciparum malaria. And it can promote Burkitt's lymphoma also. These are chronic complications which can be seen in all types. Now, the transfusion-associated malaria. So, the difference of transfusion-associated malaria with mosquito-borne malaria is the infective form is merozoite, trophozoite, or schizones, but not gametocytes. There is no pre-erythrocytic stage of development. So, directly it is the infective form. The infective form is merozoite. So, there is no need for the parasite to go to the liver. There is no pre-erythrocytic stage. Because it is not going to the liver, there is no hypnozoite formation. Since there is no hypnozoite formation, there is no relapse. Because there is no relapse, there is no need to give treatment for relapse. That is, radical chemotherapy with primaquine is not needed for transfusion-associated malaria. And the incubation period is also short. And malaria can cause complications in pregnancy like fetal distress, premature labor, low birth weight, and stillbirth. These are complications that can be seen in pregnancy. And in children, this jaundice, acute renal failure, and acute pulmonary edema are unusual. These features, these are the complications that can develop with all the species of malaria, especially with falciparum malaria. This renal failure and all, especially with falciparum malaria. But these features are not seen in children. It is unusual in children. But the complications that are seen commonly in children are convulsions, coma, hypoglycemia, metabolic acidosis, and severe anemia. These are the complications commonly seen in children. Now, the epidemiology of malaria. Malaria is the most lethal parasitic disease of humans. And the most commonly affected area is Africa, followed by Southeast Asian regions. And worldwide, if you see, Plasmodium falciparum is the most common species. And considering India, in 2018 and 2019, according to the 2018 and 2019 statistics, Uttar Pradesh was having the highest malaria burden. And the species most commonly seen was Plasmodium vivax, more than 50% of cases, followed by Plasmodium falciparum, 46% of the cases. So, about malaria elimination. So, WHO has initiated the global technical strategy for malaria elimination. And it aims to eliminate malaria by the year 2030 globally. And in line with this WHO strategy, India has also launched the National Framework for Malaria Elimination. It was in 2016, and this is in collaboration with the National Vector-Borne Disease Control Program. So this National Vector-Borne Disease Control Program aims in controlling 6 vector-borne diseases. So in that, one is malaria. Aim is to eliminate malaria by 2030. So for that, all the states and union territories of India are stratified into 4 categories based on the annual parasite incidence. Coming to the laboratory diagnosis of malaria, the gold standard test for diagnosing malaria is peripheral blood smear. The specimen it is collected from the earlobe or by finger prick or the pricking from the great toe in case of infants. And you have to collect the blood at the height of the paroxysm of fever and before taking antimalarials. So once after the hike of the paroxysm of fever, few hours later, you can collect the blood and before taking antimalarial drugs. You have to collect at least twice daily till the parasites are detected. If you are suspecting clinically malaria, you have to collect at least twice daily. Samples you have to collect at least twice daily until the parasites are detected. And you have to make both thin film as well as thick film. So to prepare thick film, you have to keep 4 drops of blood on the slide and just make it like a circle. You have to spread it in the form of a circle, and it is thick film. And thin film, you have to keep 1 drop of blood on the microscopic slide, take another glass slide and make it like a tongue-shaped smear. And it is a feathery tail end of the smear that you have to screen for the parasites. So after preparing the smears are stained with the Romanowski stains like Leishman, Ginza and Field, Wright stain or JSB stain. Jaswant Singh Bhattacharya, JSB stain. And it is screened near the feathery tail end. So the thin smear, it has got the advantage of speciation of malarial parasite. We can do speciation of parasite using the thin smear. So these are the features that helps in speciation of the parasite. So for speciation, we will check the morphology of the early trophozoite, the late trophozoite, the schizon, the number of merozoites inside the schizon, the female gametocyte and male gametocyte morphology. So coming from Plasmodium ovale, that is Plasmodium ovale, the RBC shape will be not smooth. It will not be a round, smooth RBC. The RBC will be appearing irregular. Surface of the RBC will be irregular in case of Plasmodium ovale. That is seen only for Plasmodium ovale. So fimbriated RBC you can see in case of Plasmodium ovale, enlarged fimbriated RBC. Then coming to early trophozoite form. Early trophozoite form is known as ring form. So Plasmodium ovale, Malaria and vivax, you are seeing only 1 ring forms each. But in Plasmodium falciparum, you can see multiple ring forms. Multiple ring forms. Then acoliforms. Acoliforms are ring form attached to the RBC membrane. Then the headphone shaped ring forms or double dot ring forms. These are peculiarities of ring forms in Plasmodium falciparum. So multiple ring form, acoliform, double dot ring form or headphone shaped ring form. All these are peculiarities of ring form in Plasmodium falciparum. Then the late trophozoite is also known as amoeboid form, and the amoeboid form has got a peculiar shape in Plasmodium malariae, that is band shaped amoeboid form seen in Plasmodium malariae. And the number of schizons, number of merozoites present inside the schizon will vary for different species. Based on that number also we can speciate. And the gametocyte, all the gametocytes will be roughly spherical except for Plasmodium falciparum, where you will be seeing banana-shaped gametocytes, female and male gametocytes will be banana-shaped in case of Plasmodium falciparum. These are the features that help in speciation, and also the malarial pigments can also be seen. Based on the malarial pigments also you can speciate. That is for certain species, the peculiar appearance of the pigments and all. This is the peripheral smear finding. You can see the ring form in case of Plasmodium vivax. All these in case of Plasmodium vivax, ring form, amoeboid form. This is the schizon with the merozoites inside. Male gametocyte, it is spherical only. This is also female gametocyte, spherical. Now this is Plasmodium falciparum. You can see the acoliforms, that is a ring form attached to the RBC membrane. Multiple ring forms, headphone shaped ring form. All these are seen in Plasmodium falciparum. Then the banana shaped gametocyte of Plasmodium falciparum. This is the female gametocyte. This is the male gametocyte. Then this is the band form of Plasmodium malariae. This is the late trophocyte or amoeboid form. This is appearing like a band. So it is band form seen in Plasmodium malariae. This is the ovale, ring form in ovale. We can see the RBC is fimbriated. Now the advantages of thick smear is helpful in quantification. It is helpful in detecting the parasite, and it is more sensitive because it can detect as low as 5 to 10 parasite per microliter of blood. And it can help in quantification of the parasite. So first you have to check in thick smear whether you are seeing the parasite. Then you can quantify. Then for speciation you have to see the thin smear. And thick smear, it can also demonstrate the malarial pigments. Other than the peripheral smear examination, other tests which you can do are fluorescent microscopy, which is known as Kawamoto technique. That is staining using some fluorescent dye and examining under the fluorescent microscope. Another method using the fluorescence technique is quantitative buffy coat examination. To do the quantitative buffy coat examination, we'll take blood in a capillary tube which is lined with acridine orange. 60 microliter of blood is collected in a capillary tube coated internally with acridine orange. And this will be centrifuged so that the distinct layers are formed, discrete layers are formed, RBC, WBC, and platelets will be separated. And the buffy coat area is examined under the ultraviolet light to see the gametocytes, the ring forms and all. This is how, this is the capillary tube in which layers are separated. You can examine the buffy coat layer for the crescent shaped gametocytes of the Plasmodium falciparum. The ring forms of Plasmodium falciparum, etc. will be seen as brilliant green dots, dot-like brilliant green appearance. Other non-microscopic tests are antigen detection test. These are rapid diagnostic tests, which we can do using immunochromatography method. So the antigens that are present in malaria are the LDH and aldolase. LDH is lactate dehydrogenase, then aldolase, and this will be present in all the malarial species. And Plasmodium falciparum has got a specific antigen known as histidine-rich protein 2. So we have got test kits that can detect pan-malarial antigen as well as the antigen which is specific for Plasmodium falciparum. This is the immunochromatography test format. So the control line should be present for all the tests, then only it is valid. So this test is invalid. Coming to the other test, this is control line alone is positive. Test line is not showing any band, so it is negative. This one is showing control line positive and test line also, the band is there. So this band is anti-malarial antibody which is there for all species. That is the pan-malarial antibody is positive. So we can tell this band is for the upper band is for anti-falciparum antibody. This lower band is for anti-malarial antibody that is present in all the species. So for this patient, this line is coming as positive, which means it is not falciparum because that line is not turning up. So that is not falciparum. It can be any other species. So non-falciparum malaria. Coming to this test, both the bands are coming positive. So anti-malarial antibody for all the species is positive and falciparum also positive. So we can tell it is either Plasmodium falciparum alone or it can be a mixed infection also. It can be a mixed infection also with other species. And this test is invalid because control line is not coming. So this is how the antigen detection is done. The advantages of rapid diagnostic test is it is simple to perform and it is more sensitive also. And it can be used for telling the prognosis also. For example, the lactate dehydrogenase enzyme, it is produced only by viable parasites. So that is the antigen that we are testing. So it is produced only by viable parasites. So once the parasites are killed, that line will not turn up. So it is used to monitor the response to treatment. But anyway, microscopy is the best way to assess the prognosis. And other advantages are HRP2 is a reliable marker to diagnose malaria in pregnancy. That is, in case of pregnancy, you can do a rapid diagnostic test to detect the HRP2. That is another advantage of the rapid diagnostic test. Then the intensity of the band is directly proportional to the parasitemia and severity of the disease. So the severity and parasitemia can also be assessed by the rapid diagnostic test. These are advantages of rapid diagnostic test. Other tests that can be used are culture. Culture, usually we will do only for preparation of malarial antigen, usually not done for diagnosis. The culture media is RPMI 1640 medium. RPMI is Roswell Park Memorial Institute 1640 medium. Usually we culture only for preparation of antigens, not for diagnosis. And molecular methods we can use, that is PCR targeting 18S ribosomal DNA. Then antibody detection. So antigen detection we have seen, but antibody detection, it is not used in India because it measures only past exposure. The antibodies can persist even after clinical cure. Therefore, we are not using antibody detection kits. Now, the difference in laboratory diagnosis for Plasmodium knowlesi from the other species. Actually, Plasmodium knowlesi, the diagnostic features are a mix-up of all the other species. That is, the early trophozoite of Plasmodium knowlesi is same as that of Plasmodium falciparum. And the late trophozoite and gametocytes are similar to that of Plasmodium malariae. That is how you can diagnose Plasmodium knowlesi. And no specific rapid diagnostic test is available for knowlesi. We can do some PCR assays. Now coming to the treatment for malaria. These are the class of anti-malarial drugs. First one is quinolines and related compounds, then artemisinin and derivatives, hydroxynaptoquinones, biguanide derivatives, diaminopyrimidines, sulfonamides, and tetracycline. Under the quinolines group will come chloroquine, quinine, mefloquine, and primaquine. And the quinine, it is active against gametocytes except for Plasmodium falciparum. Chloroquine and mefloquine, it is active against asexual RBC stages only. And primaquine, it is active against the hypnozoites. That is why it can be used to prevent relapse. Then artemisinin and its derivatives include artemisinin, artemether, arteether. They are active against both asexual RBC stages as well as gametocytes. Then this hydroxynaptoquinone, that is atovaquone, and biguanide derivative proguanil, both are active against the asexual RBC stages and the liver stages only for Plasmodium falciparum. These are active against the liver stages but only for Plasmodium falciparum. Then diaminopyrimidine is pyrimethamine, active against the asexual RBC stage and liver stage plus or minus. It can be active or will not work. Sulfonamides, sulfadiazine and sulfadoxine. Tetracycline and doxycycline. It is active against asexual RBC stages. It can or sometimes even it will not work. See, these are the National Vector-Borne Disease Control Program guidelines for treatment of vivax malaria. Vivax malaria is benign malaria. We can give chloroquine 25 mg per kg divided over 3 days. That is 10 mg per kg on day 1 and day 2 and 5 mg per kg on day 3. Totally 25 mg per kg divided over 3 days. And primaquine to kill the hypnozoites. 0.25 mg per kg body weight. You have to give daily for 14 days. It is contraindicated in infants, pregnant women, and individuals with G6PD deficiency. This is the treatment for vivax malaria. And treatment for falciparum malaria is because falciparum malaria has got resistance to chloroquine. So we are using other drug, that is artemisinin combination therapy, ACT. Artemisinin combination therapy, that is co-formulated tablet of artemether and lumefantrine. Artemether and lumefantrine. Total dose of 80 mg by 480 mg. Artemether and lumefantrine 80 mg and 480 mg in adults, given over twice daily for 3 days, plus Primaquine single dose. And this is contraindicated in the first trimester pregnancy and children less than 5 kg. This is for northeastern states. In northeastern states, we will give this combination, artemether and lumefantrine. But in other states, we will give artesunate for 3 days plus sulfadoxine and pyrimethamine. Sulfadoxine, pyrimethamine. Also, Primaquine 0.75 mg per kg, single dose on the second day. So that is northeastern states, artemether, lumefantrine. Other states, artesunate, sulfadoxine, pyrimethamine. This is the treatment for falciparum malaria. And in uncomplicated Plasmodium falciparum cases in pregnancy, quinine is the drug we can give. That is first trimester, quinine. Second or third trimester, area-specific artemisinin combination therapy. Because falciparum, mostly it will be resistant to that group, chloroquine, quinine and all. So, you can give area-specific artemisinin combination therapy in second or third trimester. In mixed infection, that is Plasmodium vivax plus Plasmodium falciparum, you can give combination therapy of artemether, lumefantrine, and artesunate, sulfadoxine, pyrimethamine as per geographical area plus Primaquine for 14 days. In mixed infection also, even if other species are involved, it is better to give the treatment for Plasmodium falciparum. Treatment options available for severe malaria is artesunate 2.4 mg per kg IV given on admission, then at 12 and 24 hours, then once a day. Similarly, quinine, artemether, and arteether. These are treatment options available for severe malaria. So, drug resistance in malaria, many of the strains of Plasmodium falciparum are multi-drug resistant, that is resistance to at least more than or equal to 3 classes of anti-malarial drugs. But artemisinin resistance has not been reported, so we can give artemisinin. In India, Plasmodium falciparum, chloroquine resistance has been reported since 1973. The factors that contribute to the emergence of resistance in Plasmodium falciparum is longer half-life of the drug and mutation in the parasitic gene and inadequate and irregular usage of the drug and host immunity. All these are the factors that contribute to emergence of resistance, mainly mutation and inadequate dosage of the drug. Drug resistance in vivax malaria, only sporadic cases of resistance to chloroquine or primaquine have been reported, and in areas of India, Burma, Indonesia, and few others. So vivax is not typically, not always resistant to chloroquine. Only very few cases are reported. Coming to the prophylaxis against malaria, chemoprophylaxis is there, vector control strategies, and vaccine. For chemoprophylaxis, for short-term chemoprophylaxis, that is giving for less than 6 weeks duration, doxycycline is recommended at a dose of 100 mg daily in adults and 1.5 mg per kg for children. It is started 2 days before travel and continued for 4 weeks after leaving the malaria endemic area. So chemoprophylaxis is indicated for travelers, and for short-term chemoprophylaxis, we can consider doxycycline. Has to be started 2 days before travel and continued for 4 weeks after leaving the malaria endemic area. And for long-term chemoprophylaxis that is given more than 6 weeks, mefloquine is recommended at a dose of 5 mg per kg weekly and administered 2 weeks before, during, and 4 weeks after leaving the area. 2 weeks before going to the area, during, and 4 weeks after leaving the area. Mefloquine is a drug which has to be given weekly. Now, the vector control strategies are anti-adult measures like residual insecticide spraying, DDT, malathion, and phenitrophthione, space fogging of the pesticides, then insecticide-treated bed nets, repellents, and protective clothing we can use. And anti-larval measures are, there are larvicidal oils that like mineral oil or Paris green, which can kill the mosquito larvae and pupae, and source reduction. That is weekly, we have to observe the dry day. Dry day, that is throwing of the water, which are collected in small collection areas. We have to throw it off, and that is source reduction. so that mosquito will not be breeding. Then biological larvicides like Gambusia affinis, it is a fish, and Bacillus thuringiensis, that is a bacteria that can be used to kill the mosquito larva. These are biological larvicides. Finally, vaccines. Vaccine for malaria is RTS-AS01. That is the only vaccine candidate that has completed the phase 3 trial. It is a pre-erythrocytic stage vaccine, pre-erythrocytic vaccine, and it contains Plasmodium falciparum circumsporozoite protein, and it is fused with hepatitis B surface antigen and a chemical adjuvant AS01. This is a chemical adjuvant AS01, and S is for the hepatitis B surface antigen, and it's a recombinant vaccine, and it uses the Plasmodium falciparum circumsporozoite protein. It's a pre-erythrocytic vaccine. That finishes the topic. Thank you for listening.